Hello everyone, this is Koran Soylu. Today we will try to show how we treat septal branch perforation that occurs during the retrograde CTO procedure with subcutaneous fat embolization. In this slide, you see the patient's RCA CTO occlusion with dual injection. A very long segment CTO. The proximal cap is unclear. And the distal vascular bed is poorly calibrated. So we decided to start with a primary retrograde strategy. You can see the safety wire we placed in the LAD. Then we entered the septal artery originating from the midsection with fine cross microcatheter. You can see the tip injection of distal septal branch. There was CC2 septal collateral connection. A samurai RC wire successfully passed from this septal branch to the RCA. However, due to distal tortuosity, the microcatheter did not advance. After various manipulations failed, we decided to perform balloon dilatation on this tortuosity area. We performed dilatation with a 1 mm Artemis balloon at 4 atmospheres. However, after balloon dilatation, we observed a perforation of the septal branch. It was an Ellis Type perforation. At this stage, we inflated the same balloon at the perforation site to limit the perforation. We decided to proceed with the CTO procedure with an antegrade approach while performing prolonged balloon dilatation in the septal perforated artery. At this time, the patient has not yet experienced any hemodynamical or clinical problems. We began the procedure with a Gaia-3 wire during the antegrade procedure. However, our wire advanced subintimally in the distal section. We were unable to reach the true lumen. During these attempts, the patients developed chest pain and hemodynamic instability. We observed the thrombotic activation in the mid-LAD segment. The plaque here was likely activated due to microcatheter and balloon manipulations. Because LAD flow was also observed to impaired, we interrupted the CTO procedure and placed a stent there. After the stent was placed, the septal branch was rewired and the microcatheter was advanced back into the septal branch. Perforation was continued in the tip injection of the septal branch. The patient also experienced hypotension. Pericardiocentesis was performed because the tamponade was beginning to develop. The patient stabilized after pericardiocentesis. We decided to occlude the septal branch with subcutaneous fat to stop the perforation. You can see the pericardiocentesis needle. You are currently watching the video we shot after the procedure to better understand the procedure. A subcutaneous fat excision was performed from the patient's femoral region after local anesthesia for the fat sample. A very small section of the removed tissue was placed into the proximal microcatheter port then the port was inverted. The fat, lighter than water, was expected to migrate into the microcatheter lumen. However, because the fat adhered to the port edges, these maneuvers was facilitated by using a reverse of the floppy wire. The fat needed to pass through the narrow microcatheter lumen and reach to the distal septal branch. To achieve this, the microcatheter was connected to the indeflator to generate a powerful thrust. The fat pushed by the indeflator was thus embolized to the ruptured area. After this procedure, the perforation flow was stopped. The procedure was terminated to be planned later for CTO intervention. Coronary perforation is a life-threatening complication that can occur during CTO procedures. When the perforated artery is a small branch, embolizing agents such as coils can be used. In cases where coil use is not possible, fat embolization can be a backup strategy, using the patient's own tissue and not requiring additional device experience may be advantageous. Furthermore, advancing fat tissue through the microcatheters is not easy. Therefore, a laboratory equipped with all available alternatives and operator experience is crucial for managing perforation. Thank you.